Today I am talking about training in university. So the question is how we should train is a bit of a difficult question, but we can do some reflection about training tactics. Just to introduce that the survey is not something new now, and it's more than 30 years of history we have behind us. So this has led to a real expansion, and now laparoscopic or minimally invasive liver surgery is well used everywhere. At the beginning, there were few things which have delayed this expansion, and importantly was the technical challenges which were perceived about minimally invasive surgery and led to an important resistance. However, the effort or the contribution of pioneers to demonstrate the safety and the feasibility, and also to invent and introduce techniques and tips and tricks, has been very important and instrumental to push further this technique. However, we always have on the back of our minds that the most important thing when you introduce a new technique, that you don't cause harm, and then you don't shift paradigms in a negative way. And harm is any injury that can be caused to patients, whether it's intentional or non-intentional, it's a harm. One of the most important studies I done was this paper looking at conversion in minimally invasive liver surgery, and that was in 2017, taking 3,000 patients from the pioneers of minimally invasive surgery in Europe. And I wasn't surprised to find that 10% of these have been converted, and I knew that the majority of these were converted because of bleeding, because this is what scares surgeons and let them convert. But I was surprised to see that conversion was associated with a significant high morbidity and significant high mortality. So mortality was something like 5% in these cases. However, this has led to me thinking why these people die if you convert, why you don't save them. And then before publishing, we went to look through this paper better and to find what type of conversions, and we ended up identifying two types of conversions. One conversion, which is an elective conversion. So you open a patient, you put the camera in, a lot of adhesions, today I'm tired, let me convert. Why this patient should die? Why should have this high mortality? And in fact, this type of patient, which is converted electively, early, without a problem, in this group of patients, the mortality is similar to open surgery mortality or even less. So not a problem. But the problem we found was that when you convert because of an emergency, because there has been a problem, an injury, a harm during surgery, and you convert, this group of patients have a 5-fold increase in mortality. So this is a big problem. 10% of patients who've been converted because of a problem like hole in the vena cava, bleeding from the portal vein, hole in the colon, whatever, these patients die at 10% rate. So that's really dangerous. So it means that if you want to do the surgery, you shouldn't have this problem. And if you want to do the surgery and you shouldn't have this problem, obviously you should be trained. At the consensus guidelines of Southampton, we looked at a number of domains, techniques, etc. But one of the important things was that every liver surgeon should have surgeons who do laparoscopic liver surgery. And should be more than one. But the character of these ones should be that they are competent in laparoscopic liver surgery. So competent doesn't mean that they can do it. Competent means that they can do it very well. Actually, important thing about this word competency, when this statement was written, instead of the word competency is a word that the British use, with interest in laparoscopic liver surgery. But the patient representative in this group refused to approve this statement and had to talk with the head of the validation committee. And when he explained, said, I don't care about somebody who has interest, who love laparoscopic surgery. I want him to be competent because I am putting my life between his hands. So this put on the shoulders of pioneers a very big responsibility, is how we can make sure that there is a wider implementation of this technique, because that's very important. This is what we want. But in the same time, how can we make sure that this is a safe implementation, safe wider expansion? So we said you need to start in a stepwise manner to people. But after the guidelines, I just looked at this and was reading the paper, and I said, what do you mean by stepwise? What is stepwise? So which is the first step? And also, is the first step the same for every one of us? Because is all liver resections, all right hemihepatectomies difficult? Or is all left lateral sectionectomies easy? And are all surgeons equal in the way they learn and they behave? Okay? So we looked at difficulty scores, and here there was a published difficulty score by the Japanese colleagues, which if you look at it, it's just talking about the type of resection. So if you look at this and you score a segment 4A resection, you will find that it will score 3. That's easy. And you will find that a segment 4B resection will score E. But this is a patient who had the right hemihepatectomy open and then have a lesion in segment 4. And imagine I was doing this laparoscopically, and of course this space you see is after I have mobilized a lot with my fingers to gain space to enter and put some ports. The other one had a right hemihepatectomy laparoscopic, and there is a lesion in segment 4A attached to the vena cava. And both need the resection, and that resection based on the Japanese classification is an easy resection. So if we talk about stepwise and if we use that scoring system, then we'll be telling people, look, you can start with this to build up your skills. But these are two of the most difficult, specifically the one after open surgery, the most difficult ones I think I've done. It's one of the, I am sure gaining Bringle maneuver on these was really a very hard job, and you have to invent a lot and try to find a way to get through. So in my view, these are not easy. These are quite difficult. These are quite challenging. So we have failed with that so far to tell people how to start learning, or how to start applying what you learned, and how to start implementing minimally invasive surgery in your cases. I'll just go ahead for the sake of time. Then we work on developing another scoring system, and we found that people who have complications are associated with difficult cases, and people who have intraoperative complications will have postoperative complication and postoperative high mortality. And we looked into variant analysis to find which are the factors that increase the difficulty of surgery. And we find these 5 factors: neoadjuvant chemotherapy, previous open surgery, lesion type, lesion size, and resection classification, minors, majors, and technically majors. So we developed this score, and we developed this calculation and this calculator, where you can put the details of the case you have, and then you have a score which is coming from 1 to 15 and tell you where you are. And I thought this is much more nearer to reality than the Japanese score. However, is it ideal? I don't think it's ideal. So this is a case of a 2-stage hepatectomy, extended right hemihepatectomy, of lesions in the right lobe after resection of the left lobe, after portal vein embolization, with a lesion invading the middle hepatic vein, another lesion invading the right hepatic vein, so needed a full mobilization of the liver, needed to lift the posterior side of the liver, of the lesions, away from the hepatic vein. Try to see if you can gain control of the outflow whilst having resection margins. And in this specific case, you need to make sure about it, because if you do all the resection, then you find that the outflow is difficult to control, or you control it at the end and you get positive margins. So that's the control of the middle hepatic vein, and then the control of the right hepatic vein, and dividing them before finishing the resection. And all this is technical difficulty, is challenging, and challenges, which, sorry, maybe I didn't see the score here. Yeah, which may not be very represented even in our score, because this is what we put, and this is high, 7 out of 15, while I think this case should go classified as 15 or 16 out of 17. This is a resection of a small lesion in segment 2. In segment 2, but it's a redo in a patient who had 4 surgeries before, a lot of ablations. He only have his left lobe only, and only the left hepatic vein. And the lesion, after a lot of ablations, they couldn't ablate it because it was stuck to the diaphragm, to the pericardium. So if you see, we took the diaphragm, we made a hole in the pericardium, a lot of air went into the heart while we were operating, trying to find a way to pass the Pringle maneuver, and then trying to resect, maintaining the hepatic vein, the left hepatic vein, without injury, and just going aside to it, just taking the lesion with a clear margin. And this is segment 2. Everybody would say segment 2 is easy. And also, again, neither our score nor the Japanese score have worked well. So basically, we're failing in telling people what is the way to build up their practice in a sure way. We published a lot about lesions near the vascular structures, the major, which are difficult. We published about the big lesions, which are more difficult, and we warned people about this. And we said more big is the lesion, more it's difficult. Doesn't mean that you can't do it, but it's more difficult. Repeat surgery, especially after open surgery, is more difficult. Lesions in the posterior segments are more difficult. You need to leave them for the end. And before they were contraindication, I'm not saying they are contraindication, but they are not minor resection. We call them technically major resections. And we published this. We also developed, invented techniques to permit a safe resection of this, like the diamond technique that you may have seen. We changed the paradigm of minimally invasive liver resection, and we called for straight lines rather than circles to avoid having positive resection margins, etc. And we showed that we can result. Now, for the expansion of this type of approach, we needed really to have safety and to ensure safety. But who is in charge of training and ensuring safety? From my point of view, every surgeon has the responsibility to protect his practice, to have insight of his abilities and his limits. While pioneers and leaders of groups, etc., have to give guidance, they have to share their knowledge, but also they have to offer training opportunities and to develop the level of evidence regarding this. And also they have to encourage societies and mother societies to work on that. But societies need to supervise, and if they can't supervise, they need to encourage and endorse who is supervising and who is running training opportunities. And industry need to stop thinking of surgeons as clients who buy instruments, and need to partner with them and support them to develop safe practice because it's of their own best interest. Because if the robot shows that it's getting rubbish results in minimally invasive liver surgery or pancreas, then the robot will be used less. So it is the interest of everybody. And the training itself is not easy. So training is not easy, and surgery is not easy. Surgery is a very long journey. You need to have dedication. You need to be trained. You need to continuously train. And every surgeon will be trained in different stages of his life, starting from his residency as a surgeon till he is as old as me when there is a new technique or a new approach or a new something. And while sometimes in some phases of your training, when you are in residency, etc., you don't am I running too much? Am I out of time? You don't choose your trainer. Yeah. Sometimes you can choose your trainer. And there is a big difference between training and proctoring and mentoring. So proctoring is a completely different thing. Is when you are an established surgeon, you want to do a robotic liver resection, you did your training on the intuitive stuff, you went somewhere to see, maybe you tried by yourself, you did some animal lab, but now you are doing the real case and you call somebody to come to help you. Now this is normally offered by the industry or sometimes by your hospital, and it aims that the proctor offers you his knowledge and guide you through your operation. Normally proctors are paid, and it is normally typical of a novel techniques. While mentoring is something better, something wider, and something completely different in the training scale. So it can be paid and it can be not paid. Normally it's not paid. And normally you select your mentor. And normally your mentor should be somebody who has you have a lot of respect to, because he will guide you through many things. Sometimes they will go even out of surgery in your career. And anybody can have a mentor, from a medical student to a senior surgeon. Obviously there are serious surgeons who think they are the top and they don't need anything anymore. So, but I still would love to have a mentor. And there are no programs for mentoring, so there is no syllabus for mentoring. And I think, honestly, that the concept mentoring-mentee is one of the most generous and altruistic and complete form of knowledge transfer and transmission in the surgical community. And it should be developed more and more. Because this is our aim as pioneers. Don't nurture them. And if somebody would take on his shoulders the responsibility of pushing forward minimally invasive liver or pancreatic or colonic or whatever surgery, he should also make sure that he gives all what he can to training and to trainees. Now, here training is also complex, and not everybody understands training and how to train, because there are a lot of skills and a lot of things that you need to transmit, and this goes from psycho aspects to motorial aspects to technical aspects. And the psychomotorial aspect is the only thing which can complete training and can complete the trainer, where you look at the motorial element and the connective element. And this is a lot about decision making, patient selection, patient position, what to do, what not to do. And only 25% of what you can teach is motorial skills, because I can teach somebody to rotate his hand. But there are people who are gifted to rotate their hands, and there are people who, whatever you say, they are not gifted. So what we need to look is at psychomotoric learning, which starts from utilizing an instrument concept to see it, to verbalize it, to start talking about it, to practice it, to reinforce it, to reach a level of mastery in doing something or complete autonomy, and being able, obviously, after to pass at mentoring and teaching others. So you start by preparing and the concepts where everybody needs to understand what he's talking, what he's doing, what he wants, talk to who is training here, familiarizing himself with the equipment. How many times we go to do animal labs and we find somebody who's starting to learn how to do liver resection, but he doesn't know how the CUSA works, or how the harmonic works, or what's the difference between a harmonic and an NSIL, or what's the difference between a harmonic and a ligature. So it is a lot of things to do, starting from knowing what you are doing and what you are using to do. Then it is many times you find yourself that you have to teach somebody how to do a laparoscopic liver resection, but the surgeon doesn't know what are the real steps of the procedure and can confuse the steps. So the visualization is the second step. So somebody have to look at a lot of videos, a lot of live surgery, observe. Teaching comes also by demonstration, and learning comes a lot by observing. And unfortunately, many surgeons think that watching is boring, while watching can be much more important than doing. It's the time where you learn. When you do, you have nothing to learn. You practice what you know. When you look, you learn and you absorb. And there is a huge variation between surgeons on their ability to steal. If you have a clever one, he can steal concepts, steal knowledge, etc. Then there is the verbalization. So where the instructor can talk the operation through and can tell you what he's doing, and then the learner have to talk the operation through and tell you what he's doing. And it is much easier and better if you divide the procedure in models. So you can't teach somebody the right hem hepatectomy, laparoscopic right hem hepatectomy in one go. You may start saying, let's do today the mobilization, tomorrow we'll do the hilar dissection, after tomorrow we'll do the resection, after tomorrow we'll do the looking after the matrix. So the role of pioneers, again, is to create all these training opportunities with the training methodologies and to learn how to train. It's not enough to offer yourself as a trainer if you don't know how to train and what you want to train. And the training opportunities which can be created are courses, and these can be live, animal, cadaver, drive, lab, proctoring, developing of media like videos, etc., fellowships, meetings, publications, and mentoring. Because it is also important to know that all this will affect who is under you and the learning curve of the person who is under you. But we will also have to think that this curve of learning curve can be affected by all these factors, from how you train the person, how you advise him, how you attest him, how you support him, how you illuminate him, how you facilitate things for him, how you pioneer him, how you assess what he's doing, how you proctor him, how you give him feedback, and then how you mentor. And it is important to realize that the role of the trainer is essential here, because you can make this curve last 10 years. If you hate a fellow or you don't like somebody of your trainees, you can make him change career, because you can just give him always the negative feedback. You cannot help him. You can help him and make it difficult for him. You can, during the operation, just get out and make him feel bad every time, or you can really dedicate to change his life. Obviously, there are limits, because there are things that you can learn, but there are things that God has given, and these you can't influence them. There are people who are not gifted, and nothing you can do about it. So the surgical learning is a complex thing. It's a longer process where you acquire skills and knowledge, and it depends on what the teacher or the trainer do, but also what you have as gift. And the surgical learning curve is when you move from a level to another. I'll try to skip on the learning curve. But if we look at learning curves as well here, it's very important to see that the learning curves of laparoscopic liver surgery were in the early era, and they were too much different between them. People talking about 60 cases, people talking about 15 cases, etc. But these are learning curves done during the time when we were in the I or D, when there was no courses, no practice, nothing, nobody to mentor you, so you have to invent and hook in the dark to find your way. And in my view, I found that these are not valid as learning curves and as indications. So this is study 2017. I took 4 pioneers and 4 trainees who've been trained by somebody. Like there were Besling, Cherea, and Davila. They were trained by me, Wakabayashi, and there was one more trainer, and we looked at how they performed and how we performed. And to cut it short, you will see that the pioneers used to have a very long learning curve, 50 and 130 of learning curve on minors and majors, while the new people that we trained, we showed them tips and tricks. Look, the learning curves are really ridiculously short respect to the others. And this is how it shows how the importance of training for people to jump on the shoulders of the pioneers. So if I come to some conclusions, I say that the learning curves have to be reviewed anyway. This is an online calculator if anybody is interested in the learning in our difficulty score, which I spoke about. The stepwise approach is key safety, but we have to talk about what is the step line approach. And it's important to keep learning, because at any stage of anybody's career, because there are many lessons that you can learn, but the best are those who learn from other people's mistakes or maybe successes. Talking about proctoring, mentoring, guidelines, and this, I have to tell you that in May this year there will be the international guidelines on minimally invasive liver surgery, robotic and laparoscopic separately. This will be on the 7th and 8th of May in Brescia, where I live. We did the pancreas last year and it was a fantastic event. There will be a lot of talks, a lot of important discussions. But talking about training, there will be a course on minimally invasive liver surgery on the 6th. This course will have live surgery from theaters, robotic and laparoscopic. So if anybody is interested in this type of training, proctoring and mentoring, is welcome to come. Thank you very much.
Thank you very much, Mo, for this great presentation. And if there's any question from the audience, any question from the audience? Okay, we don't have any question from the audience. And I believe you have given some data on the number of the cases for the learning curve, but it's, I believe you will agree that it's all up to the mentor and the trainee. So if I'm coming to learn liver surgery, the learning curve is going to be different than someone who is going to start the liver surgery as a beginner.
Hello?
Okay, he can't hear. Can you hear me, Mo?
Yeah, I can hear you. Were you hearing me?
Yeah, I will repeat the question. You have given some numbers for the learning curve, and I believe it's all up to the level of the trainee and the mentor himself.
No. The concept of this was to say that the numbers of the learning curves which are available or were available in the literature were based on an era when we didn't have enough opportunities for people to learn from where there were no established techniques, there were no established tips and tricks. So they were in a very early phase of the ideal framework. And we saw that pioneers have a much longer learning curve. Nowadays, the learning curve of people who gone through training, through fellowships, mentorships programs, courses, etc. is much less. More somebody does to learn and to get himself trained, shorter is his learning curve. Important to say that a learning curve for X is not the same learning curve for Y. Some surgeons are, well, there are a different level of gifts of surgical dexterities, abilities between surgeons, but also different level of perception, intelligence between surgeons, and everybody have his own abilities and learning curve. So we shouldn't generalize it. We shouldn't say everybody is 40, right him is to say I passed the learning curve. There are people who will take 40, there are people who will take 20, and there are people who take 200.
Okay, thank you. If there is no other, we would like to thank you and move on to the next speaker. Thank you, Mo, and it's a great honor to have you here.